Hello everyone, Medical Level Up here. We're back again with another video. Today's video is going to be about infarct territory and identifying the culprit artery. So we'll start off with a simple fact that we've discussed in the previous videos. It's that the 2-3 AVF are the leads that are looking at the inferior aspect of the heart, as shown in this image. So the 2-3 AVF are the inferior leads, and they show a infarct in the inferior territory. The 1 in AVL are lateral leads, so they're going to show an infarct in the lateral segment of the heart. Similarly, we drew another diagram which showed us the placement of the chest leads, and these are mainly divided into the septal leads, the anterior leads, and the lateral leads. So green is demonstrated by septal, purple is demonstrated by anterior leads, and the gray over here is the lateral leads. So the gray over here, the lateral leads, it's pretty much, it has an overlapping with the lateral leads of the 1 in AVL. So that's the basic concept of identifying the territory of an infarct. Let's take it a step further, and we want to identify the culprit artery which is blocked in the case of an infarct. So first off, let's draw a heart. We just want to go over the basics of the coronary vasculature over here. So you've got the aorta over here, the pulmonary trunk. The two main arteries are the left coronary, left descending, which gives off the septal perforators or the diagonal branches. So basically the purple is showing the left main stem, the left anterior descending, and the one that turns around the heart next to the left atrium is the left circumflex, and the left anterior descending gives off the diagonal branches. So the gray over here now shows the right coronary artery, and the dotted line at the posterior aspect of the heart shows the posterior descending artery. Now the posterior descending artery can sometimes ascend from the left coronary artery as well, and this is the concept of dominance, which we will discuss later. So the first thing we want to do is we want to identify when the culprit artery is a right coronary artery. So the right coronary artery is mainly supplying the right side of the heart. So you want to see ST elevation, which is greater in lead 3 as compared to lead 2. Now, why does this happen? It happens because lead 3 is more in line with the right side of the heart as compared to lead 2. And you will have some degree of ST depressions in lead AVL, which is basically showing you the reciprocal changes. Here is a visual representation of how you see ST elevation more in lead 3 as compared to lead 2. It is just because it is more in line with the right side of the heart. So you see ST elevations like this. And then you see that the AVL is basically reciprocal changes for the right coronary artery. And you will see ST depressions in AVL. Another feature of a coronary artery, especially when it is proximal right coronary artery, is going to be the fact that there will be ST elevation in lead V1. Now, this happens because the right side of the heart is more closer to lead V1. Another good trick would be to pick up all the leads and just use right-sided leads. So instead of the traditional V1 to V6 positioning on the chest going towards the left side, you just place them going in a fashion towards the right side. So if you pick up the leads and you just place them like this, 1, 2, 3, 4, 5, 6. In this fashion, you will get the right-sided leads, and V2, V3, V4, V5, and V6 might show you ST elevation if the lesion is in the proximal right coronary artery. The next step is looking at a posterior infarct. Now, I'm not really mentioning an artery over here because this depends on dominance, like we discussed before. Dominance is what happens when the posterior descending artery arises either from the right coronary artery or from the left coronary artery, and it somewhat depends on the fact that the arterial supply to the electrical system of the heart is derived from the artery. So right dominance is when the PDA is arising from the right coronary. Left dominance is when the PDA is arising from the left coronary. In either case, what you are going to see are signs of posterior MI. Now, I've discussed this in a previous video. It is the fact that you have an infarct at the posterior aspect, shown in gray over here. You have precordial chest leads, V1 and V2, and you have ST depressions in these leads. At the same time, this is basically a mirror image of an imaginary lead placed at the posterior aspect of the torso, which is going to show us ST elevation, which is shown over here. So the artery can be coming from the right coronary or the left coronary, but the idea is that the posterior descending is the culprit artery over here, and it depends on dominance. The next step is whether to define left main versus left anterior descending. Now, the thing about these is that left main coronary occlusion is very rare in practice. You are not going to see a lot of this. Most of these people die before they reach the hospital, before any sort of intervention can happen. So what we're going to do is, this is basically based on differentiating ST elevation between AVR and V1. Say you've blocked the left main stem. The infarct is shown in gray over here, and it's over a large portion, a large chunk of the myocardium. AVR is going to detect a larger portion of this, and hence the ST elevation in AVR is going to be significantly higher than V1. Because V1 only detects a smaller portion of it, it's a unipolar limb lead. For those two reasons, it detects a smaller amount of the infarct. So ST elevation greater in AVR as compared to V1 is a strong indicator of left main disease. Again, this is very rare. In practice, you're going to see left anterior descending lesions. In this lesion, in this type of scenario, the infarct is shown in gray over here, which is over a lesser amount of area. So the ST elevation in V1 is going to be more than AVR. Again, that's because AVR is detecting a lesser chunk of the myocardium. Infarct is much more closer to V1, and that is why you see the proportionate ST elevations in the respective leads. So this is left main stem. This is very rare. This is not seen in practice a lot because most of these patients die before they reach the hospital. And this is seen more in practice, which is the left anterior descending, also known as the widowmaker. So the next one is going to be proximal left anterior descending versus the distal left anterior descending. Let's start off by drawing a heart. So we'll draw the LAD and we'll cross it out at two places. Now what tends to happen is if there is a proximal left anterior descending lesion, it is going to block the septal perforators or the diagonal branches, which are going to supply the septum. So when there is no blood flow to the septum, we already know that the septal leads are V1 and V2. They will show ST elevation. So V1 and V2 are going to show ST elevation in a proximal LAD lesion. Since there is significant damage to the septum, and the septum houses the left bundle branch and the right bundle branch, a new right bundle branch block pattern can also be significant of the fact that there is ongoing proximal LAD lesion. The reason a right bundle branch block is significant over here is because instead of a normal RSR pattern in V1, what you're going to see with an infarct is a QR pattern. The initial R wave is not going to be visible over here because of significant septal damage. So the next part is distal LAD lesions. In distal LAD lesions, some of the septal perforators will be blocked. But the thing is that now the lesion is much more closer to the apex of the heart and is much more closer to the inferior leads. So you will have some ST elevation in the septal leads and the anterior leads. So it is V1, V2, and V3. And you will also have lesser reciprocal ST segment depression in the inferior leads, because now the lesion is much more closer to the inferior leads. So in a distal LED lesion, the ST depression will be less than 1 millimeter, and in a proximal LED lesion, the ST depression will be more than 1 millimeter. The next one is relatively simple as well. It is the left circumflex. Now there is a common misconception over here. People identify left circumflex lesions as ST elevation seen in 1 and AVL. Well, that is not true. The left circumflex will show ST elevations in only leads V5 and V6. If you see ST elevation in lead 1 and lead AVL, this is much more an indicator of LAD disease as compared to left circumflex. And here is a visual representation of how left circumflex affects the V5 and V6. The next one is multivessel disease. This is relatively simple. If you see ST elevation in AVR, which is more than 0.5 millimeters, this is indicative of multivessel disease or triple vessel disease. Next variant is basically a wraparound LED. In order to understand a wraparound LED, we'll draw two hearts, one with a normal anatomy, where you see the left anterior descending over here, the right coronary artery, the PDA over here, and these are labeled. In a wraparound version, what tends to happen is the LAD is a longer coronary vessel, and it tends to wrap around the apex of the heart and goes towards the posterior aspect of the heart as well. In this case, the right coronary artery is a relatively smaller vessel. What this tends to do is it affects the posterior aspect of the heart as well. So in this case, in a normal case, the lesion is more towards the right side if it's because of the right coronary artery. And if it's a wraparound LED, the lesion is shown on the right-hand side with the gray. Now, how do you differentiate between an RCA infarct and a wraparound LED? Well, we already know the features of the RCA infarct. ST elevation greater than lead 3 more than lead 2, ST elevation in V1, and the ST elevation decreases as you progress from V1 to V4. That is what happens in an RCA infarct because the infarct is not towards the left ventricle. In a wraparound LED, the ST elevation will be more in lead 2 as compared to lead 3. Now the opposite is happening over here because the infarct is now more in line with lead 2. ST elevation in lead V1 is going to be minimal because the right side of the heart is relatively okay. And ST elevation will become progressively higher as you progress from V1 to V4 because you're going into the territory of the left ventricle and the infarct. The next one is Wellen syndrome. This is only happening in a relatively smaller percentage of people. In V1 to V4, you will have biphasic T waves or deeply inverted T waves, and this is an indicator of critical LAD stenosis. The last one is De Winter T waves. We'll discuss this in a video on T waves. It's the fact that you have hyperacute T waves with ST depressions in the precordial chest leads, and it only happens in 2% of cases of left anterior descending lesions. The last one is a relatively newer pattern known as the Aslanger pattern. It is present in only 0.5% of patients who have multivessel disease. This was discovered by a Turkish cardiologist only in 2020. There are 3 components to this. The first one is that there is going to be ST segment elevation in lead 3 and AVR, such as this. The second component is that there is going to be ST segment depression in the lateral leaves, V5 and V6. And the third component is that there's going to be ST segment elevation more in V1 as compared to V2. Thank you so much for watching. Don't forget to like, share, and subscribe to the channel. As always, feedback and questions are appreciated, and have a good day.